So with these introductory words, I think we will get going and let's have fun. Over to you, Dr. Harbans.
Can you see my screen?
We can see the screen, but we have to open the presentation, sir.
Yeah. Is it okay now?
Yeah, but yeah, full screen.
Okay, thank you, Dr. Arup, for giving me this opportunity and such a kind words, and really grateful for your generosity. And so I will come to the topic. As already mentioned, I'll be covering this topic in 3 heads: basis of toric IOL in irregular cornea, toric IOL surprise, calculate, and correcting the misalignment. So as Arup has already highlighted that if patient can afford and surgeon is confident, all patients above 1 diopter of corneal astigmatism are candidate for the toric IOLs, except if there is a progressive corneal pathology, if they are contact lens user in irregular cornea, if the children below 12 years of age. But even those patients who have got less than 1 diopter of corneal astigmatism are also candidate for the toric IOL if they are going for multifocal or EDOF IOL. So I will, if patient is going for EDOF IOL, even if it is 0.75, I will like to correct it. If the other eye had a toric IOL with excellent results, suppose patient had 1.25 toricity in one eye and after surgery he is left with 0.25, the other eye has got 0.75, I think we should still attempt to correct it or bring it to the 0.25. Against the rule astigmatism, again, if it is less than 1.9, 0.8, one can go for the toric IOL. And even if the patient's the toricity is 0.75, 0.8, 0.9, but is refractive error, that means if he's using his specs of say 1.5, 1.25, probably he is also a candidate for the toric IOL. So this is most rewarding for the patient, doctor both, and you cannot go grossly wrong in this. You can do no harm to the patient, and you really need no expensive equipment. Just a little extra effort is required. Even if you don't have anything, you can still go on with the toric IOL. And to tell you that these IOL actually work, if you see the residual refractive error, more than 60–70% of the patients will have less than 0.5, and below 1, 80 to 90% of the patient in all these studies will have below 1 diopter of astigmatism. Same is the misalignment. Misalignment usually is 2 to 3 degree or 4 degree, and beyond 10 degree is only 2 to 3% of the patients will have beyond 10 degree of misalignment, which will be significant. Another important, my thought process is, I have not seen anywhere else, because when the corneal astigmatism, suppose from 0, 180, it is 42 diopter, and at 90 degrees is 40, it is not a straight line. It's not a point. There is a plateau, then it starts dipping over here. And if this plateau is there, that means 3 to 5 degree of misalignment is really not going to cause much of the influence, because the corneal astigmatism will have some area of 5 to 10 degree where it will remain at 42 diopter. So the small misalignment will not cause much of the difference. And once we are now trying to achieve the target of post-operative astigmatism of less than 0.5, due diligence has to be given to all the factors. And factors affecting post-op results, to my mind, measurement is the key. Measuring is wrong, and the selecting the IOL is another most important part. And ultimately, surgical skill plays a very minimal role. Up to the, if I say the weightage, if I got to give, I'll give 70% weightage to the measurement, 20% to the selection of the IOL, and 10% to the surgical skill. So there are various instruments available, and all of them and most of them should be used. At least 2 to 3 instruments must be used to find out what is the actual corneal astigmatism. In my practice, what I do is I take a optical biometry and pentacam readings, and to compare whether the data are correct or not, the anterior corneal power of the pentacam is compared with the optical biometer. And the anterior corneal power up to 3 millimeter zone, because optical biometer measures in that area, should be compared. not the total corneal power, not at 4 millimeter, not at 0.1 millimeter. So we need to compare. And then look at the crowding of values, not average. So whenever you got a toric, I will ask him to bring the toricity of the 5 readings, all which has been taken, and then see if there is any outlier, discard them. If there is no crowding, then either we are dealing with the irregular cornea or we are dealing with the dry eye. Otherwise, the reading should be closer to each other. They should not be very far off. So intra or inter equipment, if there is a difference of axis more than 10 degree and power more than 0.5 diopter, we must treat the dry eye. Most of the time, wherever I have gone wrong, and because initially the astigmatism was entirely different, when the patient was operated, he was on a steroid and lubricant, his corneal astigmatism was entirely different. So use, in fact, it will not be out of the place. The patient has got a time and patient is not very far off from your place. To treat the patient with the mild response of lubricant for 1 to 3 weeks before you decide about the keratometric values. So if disagreement persists, what to do? So acceptance of the spectacles can give you the idea which way to go. If there is too much of a disagreement between the two, I trust Pentacam total corneal power and axis more than the optical biometer for my calculation and for my uses. But if refractive cylinder is matching with the optical biometry, I will trust the optical biometer. For example, if the optical biometer axis is 17, Pentacam axis is 30, but I had another patient of these values and his spectacles is using at 10 degree. His acceptance is at 10 degree, was a post-LASIK patient. So I implanted the IOL at 15 degree. So in spite of the fact that I trust Pentacam more, but if there is agreement between the two instruments, we should trust that model. That means it may be auto-K or manual keratometer or whatever may be the system. And again, when we are selecting the axis and power, if the optical biometer is giving 10 and Pentacam is giving 20, I trust Pentacam more, but I will err on the side of the optical biometer. That means I will mark the axis 20, I will mark another at 15, so that anything between 20 to 15, I should definitely not go beyond 20. Even if it is 12, 15, 17, so there is always a little bit of a doubt whether you are perfectly matched or not. So err on the side of that side. So as the power selection is concerned, aim is to have complete correction. At now, not after 5 years, what happens to the patient, it turns to the against the rule or not, but the problem is the toricity available at the IOL is in the steps of 0.75, which translates into 0.5 in the corneal plane. We know that the corneal toricity is usually between the two available powers. So what we need to do is, then these are the power influencer. When I want to decide which power to use, aging, with the rule, against the rule, posterior corneal power, SIA and incision site, anterior chamber depth and spectacles. These are the modifiers. These per se do not influence as much. I use them as an influencer to decide which side to err on. So distance visual acuity is dependent on a volume more than axis, but minus cylinder at 90 degree gives better near vision. That means the residual ATR, we are trying to overcorrect the ATR for the future, but at the same time, we need to understand the residual against rule axis gives a good for near vision. And that is probably the way of nature that it increases the asphericity of the eye as you become old. It shifts to the against rule axis so that you can see when the specs were not there, the people can still see for the near. So this is the another point to be kept in mind. So the influencer, when we talk of, if the corneal astigmatic correction needed is 1.75, then IOL available A is 1.5, B is 2 diopters. So what to choose? So if we take into the posterior corneal curvature, it increases ATR but decreases WTR. But it is only true in 85% of the cases. So that means if you are dealing with the rule astigmatism, 1.5 will be better. But if you are dealing with against rule astigmatism, then 2 will be better. So go for the 2 instead of 1.5. But if it is total corneal power by Pentacam, then this is not true because the posterior corneal curvature has been already taken into the account. Again, aging. As you know that the younger patient keep on shifting towards the ATR. So you can go for 2 diopter, and older patient, you can go for 1.5 diopter. Again, surgically induced astigmatism and incision, most of the time 2.2 millimeter incision in my hand is not more than 0.1, 0.2. So really I do not plan for that. But if it is on a steep axis incision, you are going to give the, and it is against the rule astigmatism, 1.5 is good enough, because 0.2, 0.3 you can correct with your incision by making the incision 2.75 instead of minus just 2.2. And if it is on a flat axis, then go for the 2 diopter. Same way, anterior chamber depth. So the toricity effect, as the ACIOL we put of a low power and the PCIOL is of a high power for the same patient. Same way, when the lens is closer to the cornea, it has got more effectivity than when it is away from the cornea. That means if the patient is having deep myope with say power of 12, 15, probably he needs more toricity correction. I'll go with the plus 2 diopter toricity correction. If it's a hyperope and the anterior chamber depth is 2.2, I'll go with 1.5. And again, spectral power, I always see the patient's spectral power, because one, it gives me a very good idea to explain to the patient that you have been using central power. And if luckily the central power is higher than your corneal estimate, it gives you a lot of cushion. And spectral power, if it is -2 in this patient, while the corneal estimate is 1.75, I'll go with the higher power. So B lens. So that means these all will influence which way to move, which way to err on. But otherwise, if I get dot on, I'll go with the dot on without bothering about all of them. There are various methods of marking, but there are studies to prove that there's not much of a difference between one method to another. And as simple as this marking works as well as any other method of marking. I mean, there may be a little bit of a difference, but what is important is, this is our old video, very old video, where we used to mark at sitting the patient, and patient like a confrontation test looks straight ahead and then mark it over there. But the important thing is to remember is that you are marking a reference point. You are not marking a 6 o'clock position. After putting this mark itself is 5 to 10 degrees thick. You need to analyze where exactly the 6 o'clock is. That means whether it's in the center of the mark, on the left side of the mark, or the right side of the mark, a little away from the, because when you are putting your hands, it may not go exactly at 6 o'clock. So it is the analysis, whatever, whether it's a 90 or 180 degree, wherever you are marking, you are putting a reference point and then analyze, you feel the 90 and 180 degrees. Do not presume that dot itself is 90 or 180 degree. And once you are putting an implant, use Hilon-GB or do the hydroimplantation and a surgery. Do not use the methyl cellulose, because methyl cellulose cannot be removed completely from the capsular bag. So if you use the Hilon-GB, it comes out completely. If you use the methyl cellulose, it remains there and the post-op rotation chances will be higher. This I have found out when I was using the Star Toric IOL, which I imported long time back when even the Alcon were not manufacturing the Toric IOLs. And I found the significant rotation was in the patient who used where we use the methyl cellulose. So I stopped using methyl cellulose. Either I do the hydroimplantation or use the sodium hyaluronate. So in this case, what I wanted to show, the another important point was that before you withdraw, this is infusion cannula is inside the eye. So before you withdraw, you must put an air to press it from the top. So before you withdraw, so that the lens does not pop up and the chamber does not collapse. So to summarize in the basics, the dry eye management is the key. So far as I am concerned, whenever there is a surprise, most of the time it is the dry eye, because the patient comes and immediately we want to book the patient, we can go for that. I trust Pentacam is more reliable than optical biometer and that refraction in that order. But we need to see which of the two equipments are matching with each other, or even the manual keratometer may be excellent. What I call there should be at least agreement between the two observers, or you do the 2 times examination or 2 equipments, then probably your measurement is accurate. Access is more important than power. I mean, if there's a power of 1.5 and there's 2.5, you can correct 2, but still 1.75, still you will be happy. But access, if it is more than 10 degree variation, it creates a lot of confusion. So these all are other things of power influencer. Per se, I do not give them that much of a weightage, but when I am deciding which lens to use, I see all those points before deciding. And marking is always you are marking a reference point. You are not marking exactly 90 or 180 degree. And put on another mark, you want to put which side to err upon. If suppose you are not, most of the time you may have a confusion 3, 4, 5 degree, whether I'm right or wrong, which side the error will be more given. Do not use methyl cellulose while putting an implant, and do put air on top of it. Do not keep the IOP where high when you close the incision, because if the IOP is very high, the bag may be inflated and the lens may rotate. But if the capsular bag is flat and the anterior capsule is pressing against the posterior capsule, it is not very tight, then the chances of post-op rotations are minimal.